Hearing impairment is a term used to describe any type of hearing loss, the etiology of which may be related to either conductive or sensorineural problems resulting from congenital defect, trauma, or disease. Regardless of the degree of hearing loss, any person with a hearing impairment faces communication barriers that interfere with efforts at patient teaching. There are two major types of disabilities affecting millions of people, the mental and physical. These disabilities may have a neurological, physiological, or cognitive basis that can affect thinking process and may involve sensorimotor or neuromuscular functioning. These disabilities may result from injury, disease, heredity, or congenital defect. The following 7 categories have been chosen for discussion are sensory deficit, learning disabilities, developmental disabilities, mental illness, physical disabilities, communication disorders, and chronic illness. For sensory deficits, we have hearing impairments. People with impaired hearing, both the deaf and hard of hearing, have a complete loss or a reduction in their sensitivity to sounds. Hearing loss poses a very real communication problem because deaf and hearing impaired individuals may also be unable to speak or have limited verbal abilities and often have poor vocabularies. Deaf and hearing impaired persons, like other individuals, will require health care and health education information at various periods during their life. There are several different ways to communicate with a person who is deaf. These are the sign language, written information, lip reading, and visual aids. For the lip reading, it is one common misconception among hearing persons is that people who are deaf can read lips. For visual impairments, people lose their vision and may be rendered legally blind for a variety of reasons, because of infections, accidents, poisoning, or congenital degeneration such as retinitis pigmentosa. Most recently, blindness in AIDS patients as a result of infection has been associated with the end stage of the disease. The 4 leading eye diseases associated with the aging process are macular degeneration, cataracts, glaucoma, and diabetic retinopathy. Diabetic retinopathy is a major cause of blindness, so it is likely that you will be teaching at least some visually impaired patients who are also in need of diabetes education. Learning disability has been the subject of a great deal of controversy over the years. Individuals with learning disabilities appear normal and have been found to have at least average, if not superior, intelligence. The factors that may affect learning in a learning disabled person are memory, language, motor, and integrative processing disabilities. These factors fall under 2 general readings, input and output disabilities. Input disabilities, which refer to the process of receiving and recording information in the brain, include visual perceptual, auditory perceptual, integrative processing, and memory disorders. There are 4 types of input disabilities: the visual perception disorders, auditory perceptual disorders, integrative processing disorders, and short-term or long-term memory disorders. Output disabilities refer to the process of orally responding and performing physical tasks, including language and motor disorders. For language disabilities, there are 2 types of oral language: spontaneous and demand. With spontaneous language, persons select a topic, organize their thoughts, and choose the correct words to express themselves orally. Demand language, the language used able person, may panic in answer. Motor disorders. Learning psychomotor tasks will be difficult if the individual has problems with performing gross and fine motor tasks. Often people with this type of disability will avoid such tasks because of inadequate motor skill. Attention deficit disorder. The ability to pay attention is an important prerequisite to success in school and work. Any difficult with attending skills can have an adverse effect on learning. Attention deficit disorder is an appropriate term to use in such cases because in this person's difficulties are prominent and almost always present. So in summary, it is important to stress that learning disabled people are not mentally retarded. They just learn differently. They have one or more disabilities ranging from mild to severe. Individuals' strengths and weaknesses with respect to learning can be identified through direct individualized assessment.
One of the major physical disabilities affecting the U.S. population is spinal cord injury. Approximately 10,000 new spinal cord injuries occur each year in the United States, which translates into about 40 people per million annually in the population. The spinal cord injured population has benefited directly from the introduction of advanced technologies. Not only are people surviving, but they are also living a great improved quality of life. Residual impairment from spinal cord injury affects all areas of life: physical, social, psychological, vocational, and spiritual. Typically, spinal cord injured persons are males between the ages of 16 and 30 years old. 56% of new spinal cord injuries occur within this age range, and 82% of them involve men. A fall, car accident, gunshot wound, or blow to the head are just a few potential causes of traumatic brain injury. More than 2 million traumatic brain injuries occur each year in the United States, of which 1 million are treated in the hospital and 500,000 are serious enough to require hospital admission. The treatment of people with severe brain injury is most often divided into 3 stages. 1 is acute care, 2 acute rehabilitation, 3 is the long-term rehabilitation after discharge. Communication is a universal process by which human beings exchange ideas, impart feelings, and express needs. Communication occurs in a variety of ways, including drama, music, literature, and art. It is verbal and nonverbal, and there are both sending and receiving components. Stroke or cerebrovascular accident is the most common cause of impaired communication. Expressive aphasia. When working with expressive aphasia, you might try having the person recall images, first by naming commonly used objects, example spoons, knives, forks, and then those objects in the immediate environment, example bed and table. Another strategy is having the person repeat words spoken by nurse. It is wise to begin with simple terms and work progressively to the more complex. These exercises may be carried out frequently during the day, keeping the sessions short. People with expressive aphasia will find computers a wonderful tool to assist in their emotions to communicate. Receptive aphasia. When working with someone with receptive aphasia, you need to establish a means for nonverbal communication. Usually, the tone of voice, facial expressions, gestures, and even pantomime will be effective in conveying a message. Most often, these persons are unaware of their impairment and will speak in what sounds like a correct statement. But on examination, the words do not make sense. Aphasic person also have trouble in retention and recall. It seems old personal memories return first and recent events take longer to reappear. As we attempt to work with and engage in a teaching-learning intervention, we must be aware of our own attitudes. The effort to communicate with someone without our usual speech and language is one of the more frustrating experiences. Encouragement and explanation when teaching persons with aphasia will go a long way in ensuring client participation and recovery. In teaching people with aphasia, it is easy to overestimate their understanding of speech. Dysarthria. Many people with degenerative disorders such as Parkinson's disease, multiple sclerosis, and myasthenia gravis also have dysarthria. Dysarthria is a problem with the voluntary muscle control of speech. It occurs as a consequence of damage to the control of peripheral nervous system and affects the same muscles used in eating and speaking. Several types of dysarthria exist: flaccid, spastic, ataxic, hypokinetic, or mixed. The difference in symptoms for each type depends not on the underlying disease but on the site in the nervous system that the disease strikes. Although the incidence of the various types is unknown, this category of communication problems will certainly increase as the medical treatments for the various brain diseases improve and people live longer. To improve communication with the dysarthric person, Dreher makes the following suggestions. One is, be sure the environment is quiet because you are listening to a person whose speech muscles are weak and uncoordinated. A careful listener may discern a consistent pattern in the sound errors. Ask the speaker to repeat unclear parts of the message. Concentration and intention will aid clarity. Do not simplify your message. Dysarthria does not affect comprehension. Ask questions that need only short answers to prevent exhausting the dysarthric patient with a great effort to shape sounds. Encourage the person to use more oral movement to produce each syllable, to slow the overall rate of speaking, and to speak more loudly. Ask the patient who is extremely unintelligible to gesture right or point to messages on a communication board. Laryngectomy is the surgical removal for the larynx. The larynx is the portion of your throat that houses your vocal cords, which allows you to produce sound. The larynx connects your nose and mouth to your lungs. The American Cancer Society reports that 30,000 laryngectomies are performed in the United States each year. Most of these people return to society as useful citizens. Cancer of the larynx is 5 times more common in men than in women, and it occurs most often in persons older than 60 years of age. Until recently, esophageal speech was primary method for the speaking after a laryngectomy. Esophageal speech involves taking air into the upper part of the esophagus and adapting its normal sphincters to vibrate like vocal cords. About 75% of all clients who have their larynx removed acquire some sort of speech, and most people return to work in 1 to 2 months. Tracheoesophageal speech is a more rapid restoration of speech. The speech is closer to normal in rate and phrasing, and it is more pleasing than that created with electrolyrics. On the other hand, it means the person must rely on a prosthesis, and the tracheoesophageal fistula may undergo stenosis. If an individual is unable to learn esophageal speech in 60 to 90 days after surgery, a speech aid such as a vibrator or an electronic artificial larynx is recommended. As previously noted, many of the people with laryngectomies are older and often have a difficult time adjusting to their new condition. If they are unable to use any of the aforementioned interventions, the nurse needs to be vigilant about preventing silent suffering and social isolation. It is essential that contact with other people remain intact. If none of the assistive speech devices work, the other means of nonverbal communication need to be adopted. Losing the ability to communicate can be an isolating, depressing experience.
Today, I'm giving you a short discussion and information about the topic, a special population of chronic illness, the family and chronic illness or disability, adaptive computing assessment of potential barriers to access types of adoption. The first topic is the chronic illness. And according to Lubkin, chronic illness constitutes the United States' #1 medical malady. It is impossible within the confines of this chapter to cover specific teaching strategies for each chronic illness. Unlike acute illness, which usually have clearly defined beginning and end, chronic illness is permanent. It is never completely cured. It requires the full movement of its victim. Every aspect of life is affected: physical, psychological, social, economical, and spiritual. Because successful management of chronic illness is a lifelong process. The development of good learning skill is a matter of survival. So there are 8 types of problem areas experienced by chronically ill patients. 1. Prevention of medical crisis and the management of problems once they occur. 2. Control of symptoms. 3. Carrying out prescribed regimens and the management of problems attendant on carrying out of regimens. 4. Prevention of or living with socialization that cause lessen control with others. 5. Adjustment to change in the course of the disease, whether it moves downward or enters remission. 6. Attempts on normalizing both interaction with others and lifestyle. 7. Finding the necessary money to pay for treatments or to survive despite partial or complete loss of employment. 8. Controlling attendant psychological, marital, and family problems. So the next topic is the family and chronic illness or disability. Family's reaction and perception of the chronic illness or disability rather than the illness or disability itself influence all aspects of adjustment. Families are usually the care providers and the supporter systems for the disabled person, and they need to be included in all the teaching learning interactions. The literature has documented that family participation thus have profound influence of the success of clients' rehabilitation program. Communication between and among family members is crucial. If a family has open communication, the nurse is in a good position to help and mobilize so as to obtain needed emotional and educational support. Nurses also need to value their teaching role when they work with the family, having a disabled member. Unlike families dealing with an accurately ill member, families with permanently disabled members will have intermittent contact with the healthcare system throughout their lives. Therefore, whenever teaching sessions are required, the family's availability should be primary consideration, given adequate support and resources. The next topic that I will discuss to you is about the adaptive computing. The growth of modern technology has invaded all areas of our lives, without doubt. The personal computer has become technology that has the greatest impact. As Max Klein states, the real disabled people of the future are going to those who don't have computer to use. However, computers have been inaccessible to individuals with disabilities. Computers with an appropriate adoptions have liberated people from social isolation and feelings of helplessness and instilled the feelings of self-worth and independence. Assessment barriers. Although the personal computer has been proven to change the life of a person with even the most Assessment barriers. Although the personal computer has been proven to change the life of a person with even the most severe disability, the fact remains that it is a very individualized process. Personalized computer solutions are those that respond to a particular person, not to the particular disability. There are 6 different types to identify the barriers to computer access. 1. The environment, which include the room, the table or desk on which the computer sits and the actual hardware. 2. Input, which are the devices responsible for getting information into the computer. 3. Output devices, or the part of the computer responsible for sending the information back to the user. 4. Documentation, the written text that describe how to operate the hardware or software. 5. Support, which comes into 2 forms, cognitive and human support. 6. Training, which needs to be supplied regarding to the use of the hardware, software, and adoptions. The last topic is about the types of adoptions. Whether the area of impairment is mobility, hearing, seeing, communicating, or learning disability will determine the type of adoptions. For the short summary, the shock of any disability, whether it occurs at the beginning of life or towards the end, has tremendous impact on individuals and their family. At the onset and all through the habilitation or rehabilitation process, the patient and family are met the new information to be learned. A successful habilitation or rehabilitation means acquiring knowledge and applying it to their situation.